Hi, this is Brian Kim. I want to share with you case number 260 in the best way to do cataract surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. And so this is a tiny pupil. You're going to see it's really, really small. It's also a 2+ dense lens. You're going to see that I fail to execute the double chop maneuver and I don't get a complete chop. You're going to see me struggle through a little bit with that because this is such a small pupil as well. And you're going to see the importance and power of being able to pass the chopper blindly in this small pupil case. So you can see this patient has a rather small pupil. I'm going to use a corneal marker, which will help me to center and size the Rhexus. This is my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. I like to use a cotton tip to help control the eye in case the patient has some unexpected eye movements. This is intracameral epinephrine, and this is some dispersive viscoelastic to coat the corneal endothelium, flatten the anterior capsule, as well as viscodilate the pupil. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. I use the cannula to control the eye because this patient has a little bit of a Bell's reflex. And these are the micro Rhexus forceps, sharp tip forceps. I puncture the center, pull down towards me, grabbing the right side of the tear, and very slowly and methodically going around circumferentially, using that cannula to control the Bell's reflex. And I'm able to push more viscoelastic if I need to, since that is the viscoelastic cannula. So it has multi-purposes when I use that second instrument as I'm doing the Rhexus. You can see excellent control with this forcep. Finishing off the Rhexus. Burping some viscoelastic out, coating the surface of the cornea here. And this is the capsule fornix hydrodissection technique. I place the cannula under the Rhexus edge very gently, contra-incisionally, sliding it out. You see I'm doing the little jiggle maneuver. As I'm jiggling, you can see I'm pushing the cannula and I get a nice wave, lifting the lens up with the cannula, decompressing the bag, sweeping to the edges, and now the lens begins to spin quite nicely here. Very important in this kind of case when you have that small pupil. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. With bevel down, I'm removing the surface epinuclear material. I'm sliding the chopper under the Rhexus edge contra-incisionally, the Phacoemulsification vertically sub-incisionally, and I fracture the lens in half. Turning and pronating my hand, I'm sliding the chopper under the right heminucleus. Pushing down on the lens as I do this, getting out to the equator, pulling the chopper centrally toward the Phacoemulsification and fracturing that right heminucleus in half. Sliding the chopper around that first quadrant. It's not really wanting to come up, but then I finally perseverate and I'm able to bring that one fragment up. Sliding the chopper once again underneath the Rhexus edge. And that's the point of this video is, even though the pupil is small and people might be intimidated, some people might be saying, you know, why are you putting yourself through this torture? Why don't you just put a expanding device? Well, there's a lot of reasons, but basically it requires more time, more energy, more manipulation of the tissues, the iris. And, you know, the fact is, I don't really feel like I need it. I think if you don't feel comfortable with your technique and you feel like you need to use a pupil expanding device, and by all means you must use such. But with my techniques and using the chopper to be able to hook the lens pieces, I never feel like I'm stuck. Now, as you see here, I'm trying to chop, but I'm missing because part of the lens material there has been removed and I don't really have any leverage. So I go ahead and turn the lens counterclockwise about 90 degrees. I'm able to slide the chopper around the Rhexus edge, and then I was able to perform that cross chop maneuver right there. Once I've been able to get that full thickness chop, I'm able to use some vacuum to grab that second quadrant up out of the bag, and then very slowly and methodically removing each piece. As you can see, it's very important to be able to have good control of your foot when you initiate vacuum and aspiration and when you shouldn't. As you see here, I'm being very intentional, not using vacuum and aspiration near the pupillary edge. I'm attacking the second heminucleus. I slide the chopper under the Rhexus edge contra-incisionally, fracturing the lens in half. I was able to eat that one quadrant, and then again using successive mechanical fracturing techniques. And ultimately and finally, I was able to disassemble this lens, even though I have fairly suboptimal viewing. And why is that? Because I know how to manipulate the chopper within this space. And it all boils down to learning how to slide the chopper under the Rhexus edge very confidently and safely by pronating my hand and sliding the chopper, pushing down on the lens material as I do this. Remember, the capsule is tented up. It's being tented up because there's epinucleus holding it up. But I'm sliding down below the epinuclear level, the horizontal plane. I'm down at the endonuclear level. So I'm sliding it on the endonucleus. It's nearly impossible for me to chop the capsular bag when I do this. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece, using that canyon to control the eye still. And then I always start subincisionally peeling from anterior to posterior. By peeling the cortex from anterior to posterior, you get the most clean removal of the cortex. Fortunately for me, in this case, I'm able to go around circumferentially, peeling from anterior to posterior very nicely in this case. Nice and clean bag. And I don't like to pulse BSS when it's a blind pass because I don't want to be pulsing into the iris. So I go ahead and push some cohesive viscoelastic to fill the bag. I'm trying to expand the pupil a little bit more so I can see the pupillary edge. But you can see again, a really nice clean bag. Using that cannula to control the eye. Oh, this is the LI61AO lens. I push viscoelastic before I inject the lens into the bag because I want the bag to be completely inflated. I turn the eye away from me so I can see the leading haptic going into the bag. Now I'm going with the Lester with the INA handpiece, activating infusion and retracting the pupillary edge to make sure that both haptics are indeed within the bag. And they are. I'm able to get underneath the lens, tilting it, lifting the lens with the Lester, removing all the viscoelastic from within the bag. Again, using that Lester to control the lens. By doing it this way, I'm pretty confident that both haptics are in the bag, but I'm checking nonetheless with the Lester. Again, this was a rather small pupil. So using that Lester to check is really advantageous here. And I can see that they're both in the bag. Polishing under the Rhexus edge. Removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, you can see this is a really small IFIS pupil. With IFIS, there's a high risk that you're going to grab the iris with your vacuum. But you saw I'm very careful and methodical and strategic about when I use vacuum and when I don't. I never use vacuum when I have to chop. Therefore, the chances of me eating the iris is extremely low with the double chop and cross chop technique. In this case, I did not have a complete chop with the double chop maneuver. But because I know how to position the chopper around the lens equator, I was able to rotate the lens 90 degrees, get the chopper around the lens equator, and I'm able to flank the lens peripherally between the chopper and the phaco tip, get a full thickness chop, and then hooking the lens piece, that quadrant, hooking it with the chopper, bringing it up into the central safe zone, and then emulsifying the lens piece in the central safe zone, away from the bag and away from the iris and the pupil. And therefore, in this small IFIS case and relatively dense lens, I was able to very efficiently and safely disassemble this dense lens despite getting an incomplete double chop, because I know how to manipulate both the chopper and the phaco tip, using the instruments to flank the lens and being able to effectively disassemble this lens in such a case. So I hope this was helpful to you, and I thank you for your attention.